Okay, hello everyone. Welcome to the Bite-sized seminar series on data science in general, big data. So the housekeeping rules that I need to talk about are probably only relevant to the few that are in the room. So there shouldn't be a fire alarm. If there is one, it means we need to get out the building. So it'll be single continuous alarm. We need to leave, turn right and exit the building onto Millman Street. Once we're outside, get away from the building. Any wheelchair users can use the reception, but we should avoid the reception and the atrium and the stairs if possible. And then once outside, follow instructions from fire marshals, but hopefully that won't happen. And then the other thing to note is the meeting is being recorded, so hopefully everyone is okay with that. We won't record the last speaker. She has requested that we don't record, so we'll pause it at that point. But I would like to formally introduce our first speaker, who is online. So Dr. Will Bryant is the Clinical Intelligence Unit Lead for GOSH Drive, which is the Great Ormond Street Hospital's Data Research, Innovation and Virtual Environments Unit. In his talk, he will explain what a drive is, which will be helpful, what data are available, and give examples of his projects. So welcome, Will. Feel free to share your screen and get started when you are ready.
Hi, thank you very much. Hopefully, I will be able to do some of those things that you've said successfully. So, hi, I'm Will Bryant. I've been working at GOSH for about 6 years now, doing various research consultancy for data science and essentially supporting the better use of data in the trust to make decisions. Our unit has recently been renamed as the Clinical Insights Unit to emphasize the fact that we produce insights and then other people have to actually deal with acting on those insights. But what I'm going to talk about today is more on our research support side, and hopefully it's going to be helpful for you guys. I've got 23 slides and only 20 minutes, so I may rattle through these, and any questions, do feel free to email me, and I'll try and put my email up on the screen at some point or share it in the chat. So just briefly in terms of Drive, so Drive was set up about 5 years ago, just had its 5th anniversary. It supports innovation, the novel use of data and technology within the trust, and we run a very successful process and a scheme around getting ideas from people from the trust and working with other multidisciplinary team members across the trust to determine who should deliver a solution and how it can be delivered best. Specifically, my team and the teams around me work on requests around insights from data and research. So I'll talk mostly about that today. So a tiny bit about our infrastructure. So this was set up, or has been set up over the last 5 years. We take data from our EPIC electronic patient record system through their data warehouse. And we also have legacy data back to around 2000 for some types of data. We have an ETL pipeline, so a process that takes those data, brings them together, and then delivers them in either clear or de-identified format for research and for other purposes. In the interest of time, I won't go through all the details of the pipeline, but it involves quite a lot of SQL, quite a lot of Python, and a lot of different databases, and trying to bring it all together into one harmonized whole it can be very difficult. So the data are held internally, and we push data for specific data sets for specific projects based on a governance process that we've put in place. We do have for research specifically, we have a research platform, Iridia DRE, that I'll talk about briefly now, where we can supply de-identified data that can be accessed and analyzed from from the internet through a secure role-based access control. So this can be used to share data or do analyses across multiple sites with people from elsewhere. So not just GOSH and ICH, but other places as well. In terms of the functionality, you can have files, data sets inside the platform. A project is cordoned off from any other project, so you only see your own data, your own files, your own activity. You can apply R and Python are both available inside the platform, and that includes RStudio and Jupyter. And you can also deploy Shiny apps into the platform, which means that you can put Shiny apps on top of data. So Shiny is an R-based library for creating apps. So, for instance, here is RStudio running. If you wanted to use that against the data. Generally, in terms of the data services that we provide, we're in the blue box in the Drive data teams. So the healthcare professionals put data into Epic, or tests go into Epic. We pull them out, we transform them to make them usable. We also do analyses or summaries, or researchers will do that as well, and then that insight can be fed back into the trust. All three of those legs are actually challenging, and one of the hardest parts is going from an analysis and insight into real change. So that's something that we're also we work on in the team. In terms of the types of projects we support in the trust, research, clinical audit, service evaluation, quality improvement. We do some commercial data sharing, and that involves a whole other layer of governance oversight and full anonymization of data. We also do multi-organization collaboration, research, clinical trials, and we work on clinical ops as well, so we can deliver dashboards for clinical meetings within the trust. So then specifically focusing on what I believe is the interest of the audience today. For research, there is a joint UCL or ICH GOSH research and development team. To be able to get data from us through Drive, there needs to be an R&D approval. The responsible lead for doing that is the principal investigator on the project. That PI needs to have a substantive or honorary contract with GOSH. But I think that's the case for quite a lot of people in ICH anyway. Data are de-identified as standard. There is a governance process around getting authorization for clear data, in which case we can support that as well. It's a research workspace that you use. One example of a project we did was impact of H1B mutation on CKD outcomes. That's a while ago now. I won't talk about the clinical ops that we do because of the time, but the other piece that I think is probably most useful for you is around data discovery and provision. So the sources, as I've mentioned, are EPR, Epic, legacy systems from pre-Epic. Bespoke registries are quite a common one still across the trust. So people store data in Access, Excel, SQL. FileMaker Pro is another common one. And there are other systems that potentially data can come from. HR, finance, genomics, Datix. OnBase is our document storage system. Sorry, Datix is the adverse events and near misses data set, and PACS our imaging. And another challenge we have is in terms of showing what data are available to people. So there is a data dictionary for the data warehouse in our EPR system, but it's really only used by technical teams because it's very fiddly. And in general, the extraction of data for particular projects is based on an iterative process between someone in the team creating a cohort of patients and then creating the data for those patients. And then a clinical subject matter expertise, usually the researcher themselves, saying what is relevant, what's not relevant. We have created a standard rule-based cohort generation and extraction process. As I've said, we've tried multiple times to create an automated process or a UI that a researcher could use to define a data extract. And I noticed Richard is on the call. I know he used some of the early versions of this, which were extremely difficult to navigate. And we've established that you do need to have that data engineer in the loop to help with data extraction. But that is part of the service we offer when we're providing data for research. Yeah, I don't think that's relevant. So at the moment, our available data are clinical administrative data for all the patients who've been at GOSH over the last 25 years. This is only data for when they were inside the trust. So there's outpatient data, there's inpatient data. It's not linked to GP records or anything else like that at this point. So it's inpatient and outpatient, things that have been done to the patient, so theatres, procedures, radiology, diagnostics, and also the medical clinical information about the patient, so their demographics, lab tests and vital signs, diagnoses, medications, and all number of other things that are monitored regularly on patients. We also have access to all documents. Documents aren't available by default because they can contain identifiable or identifying information. So if one does require documents or notes, then they have to be approved through R&D. But assuming that they are approved, we have notes, so clinical notes, nurses' notes, doctors' notes, discharge and referral letters, lab reports, imaging, genetics, and anything that was created as a document as part of clinical care. There are imaging data are available directly through the PACS system, and we're at the moment working on setting up an XNAT instance that would enable us to provide imaging data alongside clinical administrative data. So that's hopefully coming along in the next year or so. In terms of understanding how we present the data, we do have a partial OMOP translation for data. So some data are in the OMOP interoperable format. But what's relevant is most of it is actually provided in a custom format that was generated specifically for our team based on research requests over the last, again, 5 to 6 years. So it's not at the moment in an interoperable data model. So just in terms of the stats for what we've done, we've served up data for almost 400 projects now since 2018. We have up to 25 years of data. I think at the last count, it was 500 or 600,000 patients and hundreds of millions, possibly into the billions now of data points for those patients. As I said, data access is through the joint R&D office. You need someone with an honorary contract to lead the project. As part of that approval process, we have a data request form that then gives us information in the DRE team within Drive to help to create those data sets to upload for people to use. In terms of linkage, again, I am guessing that this is quite important. I know I've seen quite a lot of stuff from ICH over the years about trying to get data linkage across large data sets. It can happen either locally within the DRE team or the Drive team, but that requires that we have access to clear data from other sources, or we can support potentially going the other way around, the release of clear data for linkage, but that would require a number of the relevant data governance to be in place. We have a process for secure transfer of data, but we would require authorization and the relevant sign-off. Important information. So I won't go through de-identification, but we have a regular oversight from the most senior governance leads in the trust, including our Caldecott Guardian, around our de-identification processes. So, and that's to ensure that we undertake best practice around the identification of data. Data can be exported from the platform, but that does require approval through R&D, and then that will include a data management plan, which if you don't take it off the platform, you don't require a specific data management plan for a project, because we can take care of that. Just the point, data ETL is really challenging. It's a really important part of what we do, and sometimes if we get it right, it's completely invisible, so it often doesn't get the credit it deserves. And we also use these data sets regularly for non-research projects, as I mentioned a few of the examples up above. So that was the 20 minutes. I'd be happy to talk through a couple more examples if you wanted, or unless you wanted to carry on, and I can link up with other people if they're interested.
You have time? 1 or 2 examples? Yeah, sure. But feel free. Just to mention, we'll have a Q&A session right at the end. So after all the speakers, if you could hang around for that, that would be great. Otherwise, we'll try and get the questions in now. But yeah, feel free to give 1 or 2 examples for a couple of minutes if you want.
Okay, great. So apologies, I can't stay after the talk.
Okay, then maybe we should, any pressing questions, like 1 or 2 now, and then we'll get people to email you as well.
Cool. So briefly, I haven't done. I've been doing less research support recently. We do. As I say, there have been 400 or so projects. There are a few looking at, for instance, antimicrobial resistance, so looking at all medications for antimicrobials across the entire trust for a number of years. The current projects that I oversee are operational analytics projects within the trust, so looking at bed days, patient stays, cancellations and flow, so demand and capacity work. And also looking at potentially whether you can create data science solutions to feed into clinical operations or ops within the trust in general, to improve efficiency and activity rates, which are high priorities in the trust. So that's the kind of stuff that's at the top of my mind at the moment.
Just one question in chat.
Great, yeah, thank you. And there's one question in the chat.
How much compute power is available in research workspaces for analysing large data sets?
Yeah, good question. So the base platform is probably reasonably beefy PC-ish, but there's no sort of what do you call it, graphics card, GPU. You can attach VMs, so it's based in Azure, so you can attach VMs, arbitrary VMs from Azure onto the platform, but that does have a cost associated with it. And then when those are attached, they're attached to your specific project, so they can be run. They can access all the data that you can see, and you can run arbitrary. I say arbitrary. It's an academic budget, so not quite arbitrary compute power to bring to your problems.
Thanks. And we just have Terence with his hands up in the audience.
Can you hear me okay?
Yeah, we can hear you. Thanks.
Yep.
Well, I really enjoyed that, and I've heard Neil present on this several times, and I think it's very exciting, but I think it would bring it to life, a sort of worked example of rather than the architecture and the background of taking something from DRE and showing it the journey from extracting it, analyzing it, presenting it, and how it impacted on clinical service either at GOSH or nationally would be really enlightening, I think, for those of us who don't live and breathe all the Python.
Yes, I'd need a little time to bring that together, but I'd be more than happy to come back and present. Perhaps we could get a couple of examples, and I could get some of the other people from the team to present some of the work and the impact.
Thanks.
Yeah, thanks for the idea. We'll definitely keep that in mind for future bite-sized seminars or similar. Yes.
Thank you for the talk. I have two questions. Are you planning to go back further in time before you cut off of 2000 for getting the data available? And the second question is, how long are you able to provide some IT support if we get stuck along the way during the research process, extracting the data?
Yeah, so the first question is, I can answer fairly easily. No, we're not intending on going further. So the computer-based records from pre-2000 are very poor data quality, and if you imagine that a lot of systems came online in the 2010s, so there's no data for certain types back to 2000. We do, however, have a complete record of documents going back a long way. So there are loads and loads of documents. A lot of them were scanned as images. So there's a big challenge, or handwritten. So there is information pre-2000, but there would have to be a lot of effort to extract it. The second question, yes, in terms of technical issues, there's Iridia have a support. In terms of kind of process issues and data extraction and things. So as I say, a data engineer oversees the extraction of the data. So they do the technical pieces, they work with the team to define the data set, and then the data set's provided into the platform. Then using the platform and beginning to analyze the data, we have a regular support service where we can provide ad hoc 1-hour sessions to look at specific issues, or if you need an overview of the platform, or if you come across a specific issue that you can't work out. We don't have I wouldn't say we yet have a thriving community of sort of researchers who are kind of interacting and talking about problems they're having in terms of what they're trying to do. And I think ICH is a lot better at that than us. But in terms of if you know what you want to do, trying to implement it, we're strong on that, and we can definitely assist. Yeah.
Thank you.
Thank you. One final comment is from Richard in the chat. Will, do you want to mention costing into research studies?
Costing, did you say?
Yeah, it's in the chat asking if you want to mention costing into research studies.
Yeah, so I think that there's an ongoing question. So we don't sit within R&D, we sit within innovation. And so the funding model has been traditionally that we're funded partly by the trust and partly by the charity. However, in terms of individual projects, if they are intending on using the service, there is a charge that should be included in any grant proposal. So that has to be done through R&D, and they should be able to give an indication of what that is at the point of application.
Okay, thank
or
you.
the point of writing the application.
Yeah, makes sense. Okay, final question. Also from Richard. ChatGPT, for example, have shown how it's possible to take a photo of handwritten notes, convert this into text. Would this be something that you could imagine happening in the future with Drive?
Yes, yeah, absolutely. So we're already undertaking a sort of NLP from the documents where you can extract the words as strings, as text. And I could see it going back. I think that there is a challenge about how, measuring up the cost, the effort versus the benefit of having some of this extra data. But then again, if ChatGPT or foundation models, LLMs become cheaper and cheaper and easier to use, potentially that balance tips, and then someone will want to do it in the trust and will put together a program to do that.
Okay. Thank you so much, Will. That was really interesting and insightful. Yeah, if you could just post your email address in the chat. Anyone else who has questions, feel free to get in touch with Will. And yeah, thank you. We will
Thank you very
next be having Dr. Matt J, who is a senior data scientist in public health and has extensive expertise working on eChild, which is a database linking data on health and education for all children in England. Thank you, Matt.
Very much, thank you. Fab, okay, yeah. So I'm just going to give a quick presentation to present to you, tell you about eChild, so what it is, what information is contained within it. I'll show you some of the examples of how it can be used and talk a bit about the community of practice we're trying to kind of, I guess, foster and kind of develop, and some of the things that we're doing to try and bring kind of the entry bar down a bit to make using finding, accessing and using this kind of data a bit easier. So eChild links together two of the largest data sets in the country, children at least anyway, the hospital episode statistics and the National Pupil Database. So HES is a data set that covers all NHS funded inpatient admissions, outpatient attendances and A&E attendances. And in fact, also we now have mental health data in here. We have maternity data, community services data as well. And that's linked, as I say, to the NPD, or National Pupil Database, which is a data set covering all children enrolled in state schools in England. So it has information about their pupil characteristics, their special educational needs provision, absences, exclusion, exam results, and so on. And kind of as a subset of the NPD, or really, actually it's two separate data sets. And we have the social care data, so data on children referred to social care departments and children looked after in state care. So I think it's not 20, I think it's not, maybe it's more than 20 million, something like 20 million. I can't remember what it is now exactly. I may make a mistake here, but it's everyone born since September 1984. So that gives us follow up to about age 38, I think. We'll soon see though, actually, that not everyone has got data from birth to age 38 because of different coverage of the different modules in the NPD. But the point is, it's a very large data set, very comprehensive data set. What I haven't said is that, so state schools each year, it's about 93% of children are enrolled in state schools. And then on top of that, you'll have children who kind of move in and out of private education. So actually it's probably about 97% of children are captured in the NPD at some point. And in the health data, particularly in the inpatient records, 97, 98% of births occur in NHS hospitals. So again, we have a pretty good coverage of the entire population. Access is through the, I'll talk a bit about how to access the data towards the end of this talk, but you access the data through the Office for National Statistics Secure Research Service, or the SRS, which is also, it's a kind of a walled garden approach to accessing data. So you log on, it looks like it's a Windows server, but you don't have internet access when you're in there, and to get things exported, you have to email ONS and they check that your outputs are compliant with disclosure control rules and that kind of thing. So lots of safeguards at every step that kind of minimize the data that you're accessing and kind of making sure to say that outputs are safe as well. The data are longitudinal, so we can follow up people over time. And so this gives you an example, the kind of, a hypothetical trajectory of someone that you might see in the data. So we capture their birth in HES, we can see their admissions, their A&E visits. We can see when they start school, when they get SEND provision, we can see if they're absent from school or excluded, and we get exam results as well. This particular child also has social care involvement. And then for young women who give birth, we also see those as well. And so we can actually look at intergenerational factors, at least between mothers and children, because we have a mother-baby link. And so we have, for example, someone at the moment, Steffi, a research assistant, looking at the health and education outcomes of children who were born to mothers where the mothers had a social worker as teenagers. Right, so you can really get a good idea of the very kind of complex trajectories across childhood and into early adulthood among, well, not whole families, because we don't have dads. I mean, the men and boys are in there, but we can't see that they're fathers yet. But at least mothers and children anyway. So it's a complex data set, and a set of data sets really. I'm not going to go through this. All this information, by the way, there are links on the slides to the user guides, data catalog, and so on. So you'll get that. But the reason I'm showing you this is to show you just how complex it can be. And so the yellow bars along the top are all the NPD modules. And so, for example, we have the school level pupil census. That's the kind of the core of the NPD really. So that's where you get the information about enrollments in schools and all the characteristics data. And you can see that that begins in 2001, that's academic years, and well, it goes on to present, but at the moment we have it up until 2022. Then you can see that other modules have different start and end dates. Okay, so some modules end and become subsumed in others. Some, like the Key Stage 3 data, because those exams stopped, the data obviously therefore stops. Now, health data, or health data, I should say, is financial years, just to make things a bit more complicated for us. And I think between us, I don't think we still have, we haven't quite really got our heads around how complex, you know, if a child is born on this day, how old are they? What school year should they be in at this point? It gets very complicated. But anyway, we have, as I say, we have all the hospital data, we have mental health data, and we also have birth registrations, notifications data, and mortality data as well. But when you're kind of the point of this is when you're planning a study using eChild, you really have to spend quite a lot of time thinking about who your cohort is, you know, when they were born or when they entered school. So you can start with an inception that's a school inception or a birth inception, and think carefully about, okay, what data will I actually have for them, and will that be enough to answer my research question? And if you want to do a study using eChild, it has to fall within one of our 5 permitted uses, which are very broad. Okay, the key thing is you have to be making use of both the health and the education data. But basically, kind of if your study is about health and education in children, then it will fall into one of these 5 themes, right? So we're thinking about prevention, thinking about interventions, and informing families, children, and services about health and education outcomes. And our 5th theme is about methods research. So if your study is about, you know, methodological aspects of using these linked data sets, that will also fall within our remit. The data linkage is very complex, as you can imagine. The good news is it's already been done for us and for you as researchers who are coming to this. It was quite a complex algorithm. I won't go through it in detail, but multiple steps. The point is that linkage rates are quite high. So overall, 95%. And generally speaking, as is the case with these sorts of data sets, as data quality improves over time, linkage rates improve over time as well. And so with the more recent birth cohorts, we have linkage rates of near enough 99%. But you have to be careful that it's not uniform. And so linkage rates are poorer, particularly for people who are not white and people living in poorer areas. We typically see this. It's to do with things like names not being spelled correctly or not having, you know, accurate information about people if they're moving along, for example. And so although we very often say that one of the great things about admin data is not, you know, admin data are not as affected by selection bias as traditional designs, that is true, but there is still going to be some selection bias induced, for example, by these factors of linkage. So some examples. So here is a graph from a study by Nicolas Leboy and colleagues, looking at the relationship between outcomes in primary school assessments, that's Key Stage 1, Key Stage 2, so at the start and end of primary school, sort of ages, I think kind of like 5, 6 to 10 or so, by gestational age of birth. And so along the x-axis, we have gestational age in weeks. And this is one of the key things about eChild is because we have such a large data set, we are able to go into a lot of detail that you just wouldn't be able to do with a traditional kind of sampling-based design. And so we can look at single week of gestation or these outcomes by a single week of gestation. And what this graph shows is the relative risk of not achieving the expected standard. So basically, the higher the dots, the worse the outcome. And you can see very clearly there's a really clear relationship between earlier, younger gestational age of birth and poorer outcomes. But also actually post-term children as well. There's something going on here. It's obviously not as dramatic, but because again, we have the numbers, we can see that even children born at 41, 42, 43 weeks, there is some signal there in terms of poor outcomes. Another example was some work by Louise McGraw-Lone, looking at changes in hospital activity during the COVID pandemic. And so here, looking at outpatient attendances, for example, we saw that there was a very sharp drop among all children in terms of how frequently they were going to hospital, but in this case, for outpatient appointments. But it's particularly worse among certain groups. So that big yellow bar dropping all the way to the bottom of the graph, that's children who had both provision for special educational needs and a social worker at some point. So really, probably the children who need to be there most are the ones who are missing out the most. For those interested in special educational needs provision, the HOPE study is looking at the effectiveness of SEND provision. And so another thing that we're able to do with GOS-ICH is we're starting to get much more into causal inference using observational data, which is incredibly complicated. But again, because we have the richness of data that we do have and the sample sizes, and we can look at variation across, for example, local authorities or across schools, and we can start getting into some of those questions. Here's an example from some of my own research. I thought I have to throw this in here as well, which is not yet published, so kind of hot off the press. This is looking at the cumulative incidence of having a chronic health condition. So basically, what proportion of children ever have a chronic health condition across childhood, which is a really simple question, but actually it turns out very, very hard to answer. If you look in the literature, you won't really find very much. And part of the reason for that is, firstly, it's very difficult to define a chronic health condition. It's then difficult to measure it, and it's then difficult to track people across childhood. And so one of the things that we're able to do, because in HES inpatient data, we have a mandatory diagnostic coding that's provided by the hospitals. So we have very rich diagnostic data, and we can look for a whole different range of chronic health conditions within the data. We can do that over a very long period of time, and we can do it objectively. So we're not asking people to recall anything or anything like that. And so we can answer questions like this, and the answer is 25% before age 16. So taking out some of the things that we're doing to try and make it a bit easier to use these kinds of data. So for those of you who have used admin data will know these data sets are very large, they're very messy. Often the metadata that comes from data providers either doesn't exist or is not terribly helpful. Of course, this is because these data sets are created not for us researchers, they're created to help fund the NHS or to help plan schools or whatever it is. So coming to these data sets for the first time can be quite overwhelming, can be very difficult. So we're trying to kind of lower those bars a bit. And so some of the things that we're doing, this is the eChild phenotype code list repository. So I mentioned just now that we have very rich diagnostic data in eChild. People over the years have developed a whole bunch of code lists that we can use to identify various phenotypes, so think health conditions basically. And they're kind of spread out all throughout the literature, and you have to know where they are and find them. And then the actual codes themselves are in often just PDFs, and so you have to then code them into your scripts and so on and so on and so on. That's quite difficult. And so what we're trying to do with this is put all of those code lists, at least that are relevant to eChild, into one place, formatting them in a standard way, and providing example code and scripts so that you can easily implement those in a kind of a machine readable, I suppose some aspects are then semi-automated for you. So that's now live, and you can use that. And if it's free to use whether you're eChild user or not, so do check that out. We're running regular training seminar series. The next seminar is very soon, actually, in a couple of weeks' time. I don't know when the next training session will be. That we did a 2-day training course. November was that? November. So the next training 2-day course will be in November at some point. But that will be very much a hands-on kind of course using synthetic data to kind of introduce you to the kind of structure of HES and sorts of things that we normally do to identify cohorts, identify phenotypes, and so on. We have a couple of GitHub repositories, one that is specifically for eChild, which actually really is basically empty at the moment. It just kind of hosts the website. But we will be adding more stuff to that. But the other one, the UCL CHIG is the Child Health Informatics Group, and that's a kind of group of researchers at ICH. We've been using HES and MPD for many, many years, and over those years, we've added various resources, our analysis scripts and so on to that. But the eChild one also has a discussion forum, which currently is literally just what you see on the screen now. But we're hoping this will be a place where people can go and ask us and each other questions about using eChild. So if you want to use eChild, how do you access it? The kind of short answer is email us first before you do anything, because although it is a lot easier, and to give you an idea, it's taken us 10 years to get to this point where we can open it up to other people. So getting access to linked data is extremely time consuming. It takes a very, very long time. This is a process, but it's obviously nothing like what we've had to do to get to this point. But nonetheless, have a look at the website, look at the user guide and data catalog, and then email us, and we can talk you through whether it's an eligible project and if it's a particular feasible project. And then there's some things you have to do that are ONS, so you need assured organizational connectivity, AOC, which enables you to access the SRS from your institution or from home. And there's some forms you have to fill out as well, so ethics and research accreditation panel is what RAP stands for, and data request form. So to find out more, as I say, the email address is the easiest place to go. Milagros sponsors that very well, and we'll forward it on to one of us if she can't answer it. We have our website is echild.ac.uk. The repository is code.echild, and then the user guide is docs.echild. And through those websites, you'll find, I think, pretty much everything that you'll need. And we've also produced various data resource profiles, which are journal articles that provide kind of well, not general, they provide an overview, quite a good overview of the data set. So again, if you're very new to these types of data, do have a look at those. I will ask for the slides to be sent round, so you'll have all these links. And so thank you.
Thank you, Matt. We will do Q&A at the end, so feel free to sit back down. But thank you, that was really interesting and insightful, and will be definitely good to have the slides to look at all those links that you said, the seminar as well. So finally, we'll hear from two researchers. One is in person, one is online. They have expertise in environmental epidemiology using kids' environment health cohort, a national data resource for research into how the local environment affects kids' health as they grow. So apologies for pronunciation of both of your names. Dr. Celine Akarachi,
This one's great.
who's a research fellow, and Dr. Neelafar Shari, who's a senior research fellow at GOS-ICH, who can correct my pronunciation when she comes online. But yeah, first we'll hear from Celine, and then we'll stop the recording before Neelafar starts talking. But thank you both.
Thank you so much. Thanks again. It was really good pronunciation that I will skip introducing myself. So today I'm just going to, actually me and my colleague Neelafar Shari will give highlights of kids' environment and health cohort study, which we started to set up a while ago, but still it is in progress. So it is funded by HDR UK and ADR UK, and there is really big and great team behind this work. So we are just front faces to present this work today, but the team is led by Professor Pia Hardelet. We tried to answer a couple of questions that we thought it might be interesting for you. So we defined a couple of questions that will be covered throughout the presentation. First one will be, what is the significance of the kids' environment and health cohort study? Second will be, what are the key characteristics of the kids' environment and health cohort, and what data does it include? Third question will be, what are the key steps involved in linking the data within the kids' environment and health cohort, and how can it be accessed? Also, we will talk about what progress has been made so far, and what sort of research questions could be explored using the kids' environment and health cohort. So in general, we know that environment in which we live have a great impact on physical and mental health. And when we consider children, they are much more vulnerable to environmental exposure due to their ongoing organ development or immune system development, as well as they are more likely to spend more time outside, so they become more vulnerable. So understanding this complex interplay between environment and children's health could give us some opportunity to intervene through in a large scale, like through city planning, urban design, policies that could help improving child health at the population level. So there are some very valuable studies across the UK, such as Millennium Cohort Study, the GOS-ICH, born in Bradford, and the recent one is SIGL study that focuses on Liverpool. These are all connecting sort of environmental data and health data together, but Kids Environment Health Cohort Study complement these studies across the UK in some novel ways. So the first of all, the database is national study, so it focuses on England and it covers all children born in England from 2006 onwards. So it contains almost 11 million children at the first build, but it will be updated annually. So all the information, especially health and address information that you can find in the cohort, will be de-identified. It will be linking different data sources, which includes a wide range of environmental data. I will talk about it in the next slides. And it will give us opportunity to investigate longitudinal relationships, not only cross-sectional. And I just mentioned that it will be annually updated. So it will be an ongoing study. So we have multiple data sources, which broadly include vital statistics, demographic data, health data, education data, and as well as environmental data. I think the novelty of maybe Kids Environment and Health Cohort Study is about environmental piece, because it provides us with different environmental exposure data on a very granular level. So it includes air pollution data, which will come from DEFRA. It will be annual air pollution data at the 1 by 1 kilometer grids. We have distance to road data, energy performance data, which will be at the dwelling level. Temperature data that will come from Met Office. We are planning to get daily as well as monthly averages, minimum, maximum values. We will have green space data, such as green space access and the quantity of green space available within the children's house and school environment. And we will also have information on valuation of this agency data. So in terms of data linkage, as you can all imagine, it's quite a complex journey, but just a little bit of summary. The cohort spine will be made by birth registrations and notifications. We will also have death registrations. And then we will, so this spine will have both live as well as stillbirths. We will follow live babies through administrative health data linkage throughout, starting from pregnancy and throughout childhood as well as adolescence years. So we will have information on hospital records. We will get health information from hospital records, communities dispense medicines, and also community mental health data. We will also have information on children's education data, which will come from National Pupil Database. So health data bit will be linked to the environmental data using sometimes UPRN, sometimes postcode level that will come from PDS. The linkage will be all done in a very secure environment that, was it called Data Access Platform? Yes, by ONS. The researchers will not have access to this platform, but they can just request this data to be downloaded and provided to them. The UPRN data, which is very granular, actually it is an address data at a very granular level, it's almost at the building level, will be not available, and it will be completely de-identified and anonymized, and it will be kept separately, so no researchers will have this access. They will just have linked data. I think I forgot to mention that the children's data will be also linked with their mother's hospital records. and the mother's data will go up till 1 year before pregnancy. So it is quite important because this way we will be able to allow for pregnancy-related factors that can actually modify the association between environment and child health, especially in the infancy duration. And also children which are born around 2011 and 2021, we will have their census data, and we will have the cohort linked to census data belongs to those years. I hope I'm not missing anything, but anyway, if anything is unclear at the end, I will be answering. In terms of data access, so all the data will be kept in TRE, which stands for Trusted Research Environment by ONS. So there will be a procedure of application, and all the researchers that can access the data should receive secure research training first, and also they need to provide lay summary of their project first, just to explain briefly what they're planning to do with the data. And also access and use of the ONS TRS is based on 5 SAFEs framework. I'm just trying to remember if I forgot anything else. Other things are quite, I think, general, as which applies to all other databases. They need the researchers will comply with the rules set by UCL and all other data providers. In terms of progress to date, we have received ethics approval, and we have agreed the legal basis for establishing the cohort. We are at the moment we are setting up data sharing agreements with each data provider. This is not a very linear process because sometimes we just get some hindrance during some process, and we just need to redo things, or we need to do completely something new that was not expected. For example, recently we needed to get confirmation just to use openly available data, environmental data, such as Met's office data. Usually anyone can go and download these data sets, but since we are going to reuse these data sets and link with something else, we need to get this permission just to use openly available data sets. So it adds a little bit extra time to our timeline. But good news is that ONS completed spine linkage, and they are currently linking census 2011 and 2021 to our spine. Cohort will be, this is our expectation and hope that cohort will be available to the wider research community for their application in the late 2025. This could be a little earlier, but hopefully not later than the state. So a couple of things more I forgot to mention in my slides, but also some of our team members started to work on actually data exploration. One of them is Nilüfer, so she will give more detailed information about mental health service data, which was, as far as I know from our conversations with Nilüfer, that it was really complicated and it was hard to figure out, but I think she's doing a good work to just unfold the mystery, so she will talk about that piece. I think that's all, our progress. And we have interesting website that our colleague Faith Miller is working on. Please just have a look at when you get a chance. You will find this data sources diagram, which is interactive, so you can just click and see our data providers, what data actually we are going to use. We have also Instagram, Twitter page, and if you have any question, you can always email us at this email address. And also we have many collaborators that works with us and support this project. So thanks to all of them. That's all. Thank you.
Okay, thank you. That was really sense. Nilüfer, if you're ready to share, we'll just pause.
Yeah.
We'll just pause and then feel free to start when you're ready. Hold on. Bite-sized steering committee. So I've done that so I can introduce Ania, who is also on the Bite-sized steering committee. She will host the Q&A. So please, can everyone ask questions and have a good discussion? Thank you. Yeah.
I have two questions, which I think are very stupid, so I'm going to ask them in order of increasing stupidity. So firstly, for the environmental epidemiology team, are you able to track diet? There was a food and drink icon. Can you tell the diet the patients have been on?
So I believe we don't have information on diets, but probably those icons were representing food outlet locations in the spatial data form.
Okay.
Yes.
Okay, so it's still interesting.
Yes. We can interpret, I think, something about the diet, but it's not directly about diet. It's just the food store locations, like market locations.
Okay, thank you. Second one is to all the speakers. Is there a clear distinction between your data sets, or is there a large degree of overlap?
Question?
Between the
Well, we're using some of the same sources, right? So, I mean, for example, the mental health data set is both in kids' environment and health and separately in eChild. So it's the same kind of information, but not linked in the same way. So in eChild, it's linked to NPD and social care data, and kind of that's it. With kids' environment and health, it's different. I don't know if there are, like, is yours a limited data set in any way? Or is it all
differently.
It starts differently.
Sorry, we should let you answer.
So what was the data year that you're focusing on? I mean,
Or I
We've got all of the data, basically.
and starting from,
Whenever it starts, I can't remember, yeah.
so our data starts from 2006, especially health data. And then, yeah, I mean, all of them starts from 2006. So maybe time period slightly
Go
different.
back a bit, yeah.
And also, I think geography level that we are linking is different. Probably, I saw that
That's good.
there are some postcode level information in your data sets, but we are using UPRN. It's much smaller than postcode level.
Yeah, so when
Just to explain, that's a household identifier, right? It's a household UPR, and so
Yes,
you can
yes,
look
that's-
at families or people living in the same.
So all the addressable buildings in the UK has one single UPRN record. So we have that.
I add, I think the granularity of data is different. For example, for mental health service data, we have more information, because as I understand, when you have eChild, you have HES, so the patient should go to the hospital. But in my data, in the kids' environment and cohort, it includes whenever you are in contact with mental health services. That can be, for example, if there is some problematic adolescent on the street and the has a discussion with the police, and that will show up in my mental health data, which I don't think that happens in eChild, for example. So I think another difference is the granularity of the health outcome.
Well, I mean, if it's in the mental health data, we have it in eChild. So that'll be the same. But ours is linked only on the child. And the lowest level of geography we've got in eChild is like NSOA. So it's kind of, we have local authority, then within local authority, MSOA, which is, I can't remember how many households it is, but it's kind of largish neighborhoods, essentially.
I think other maybe difference between us is we are also looking at school environments, not only actually house environments, but we have information on school addresses. So we can know what sort of environmental exposure the children are exposed to in and around schools too. I don't know if there is such aspect in it.
We know we have the school information, yeah. The other big difference though is
Link in other.
versus, we can't link other information. So we're much more limited in terms of what extra now we can bring in. But also the purposes will be a bit different. So obviously the environment and health cohort is very much about studying environment. Ours, I guess, is in a way is much broader. So you could do environmental research on ours, but you wouldn't have all the kind of environmental data they've got in kids' environment and health, then there are other things we can look at, which I guess probably I assume don't fall under your purposes.
Yeah.
So there's a mixture of different purposes and then kind of different levels of linkage and other things. But a lot of it ultimately is the same data.
So that was actually a very good question.
Neither were stupid questions, yeah.
It was a good question. We never discussed it.
No, we haven't,
before.
no.
I think also just one last difference between the two is each child will have much more data on the mums before
Yes.
giving birth,
Oh,
while your data is limited to 1 year
Just
before
the prenatal
pregnancy.
period.
So
for
the
1 year.
focus is more on children and each child has slightly broader
Does have
focus,
it all,
but then
yeah.
you will have much more postcode level data linked in that each child doesn't have at this stage. Yes?
Thanks. Thank you so much for your presentations. They were really lovely. I know you mentioned for the eChild database, there's the linkage for the mother as well.
Yep.
And maybe at some point in the future, the father.
I may have misspoken. So we have the mother. Yes, I mean, fathers are very notoriously difficult with admin data because there's no in HES and MPD. Well, MPD you don't really have adults anyway, but in HES you don't have a variable that says. So although they are in there, all the men are in there, and the fathers are therefore in there. There's no piece of information that says this man is a father to this child. Okay, so whereas with the mothers, what you have is you have a mother admitted for a birth, and then you have a birth. Right, so you can link the children there, so you know this is a mother to that child.
And they're recorded on a birth
And it's
registration.
recorded in birth registration as well. Yeah, it might be possible sometime down the line to get the UPRN, and so we could look at men in households. But it's still, I mean, many of those will be the fathers, but we don't know for sure. So it's probably no, actually, we won't get fathers. And even that UPRN is probably years, I would imagine. I don't really know, but yeah, so I slightly misspoke there.
I guess as a follow-on from that, would you ever have data that links kind of carers and guardians? So not necessarily biological mothers, but you just mentioned, let's say men living in the same household that is a father.
Yeah, no, again, I don't probably not really, because I just don't know what data set exists that gives you that information. One data set that I'm working on, different projects that we do kind of want to bring in some way. Again, this is very aspirational and there's no plans to do it immediately. Is family court data. So you have information about parents who've been through the family courts and that kind of thing. You also have social care data, so you know that if a child is looked after in state care, for example, so you know that child is in foster care. But beyond that, you don't really know, so it might be young carers, for example, we just don't really know.
Yeah, I had similar questions, so thank you. It was also, I wanted to know so I'm a lab-based researcher collecting data on an ongoing basis, obviously on a smaller scale, but do you have a tip or kind of set of guidelines that you would recommend to people who are doing the collecting that would make it easier for you to then obtain the data later? So like, what's an easy way to get data out of some institution or organization?
That's a very interesting question. So I also used to work at GOSH, and so I've kind of entered data as a kind of data entry clerk. I've worked as a data manager in GOSH, created databases, and now I'm doing this stuff. The problem is, developing systems data collection is difficult. And then we're talking about national, we're talking about hundreds of hospitals, thousands of schools and everything else. These data sources are maybe different for some of the environmental stuff, certainly, but I mean, it has an MPD at least. They're statutory returns, right? So schools have to do it, hospitals have to do it, and they have to do it in this way. There's going to be lots of variation in exactly what they do. For us as researchers, for example, we go to UCLH and we speak to the coders there, for example, and try to find out what they do. That's just one unit. We can't do that for everyone. We can't do it for all the schools and all social care departments. So we kind of just have to rely on DFE, Department for Education, NHS England, that their documentation is good enough to help us understand those things. I'm not sure, apart from in terms of you kind of collecting data, creating data, I mean, do it as rigorously as you can, I think is the only thing. I mean, when I was a welfare rights advisor, for example, I have to enter data about my clients, and then so I specialize in EU nationals. I didn't even know there was an EU national code I was supposed to be using, right? And so all those cases would have been missed in whatever database they went into. So it's kind of knowing knowing why you're doing it, I suppose, is probably, and then kind of think about what do I have to do that. But of course, you're a researcher. If you're a busy nurse in a ward, well, it's kind of irrelevant. You have to deal with the patients, and that's your priority. So what you should do is different to what you can do in practice.
Or it's about setting up the systems that allow it to be easily done. So if someone else.
Okay, well, that sort of thing. Yeah, I mean, standardized processes, things like, don't use Excel, use a database application with a front-end data entry thing that checks for errors, so you can easily program things that, if the patient is born on this day, they obviously can't have activity before that. You can, all those kind of basic logic checks, you can do that kind of stuff.
Yeah, because we have, a lot of the work we have is in Excel, which I'm also struggling to try and see how do we move that to a database where we don't have the expertise to build it and we don't have clinicians with time to do it.
Access is a good kind of, stepping block, because with Access, it's a database, and you can, within Access, build a form which has logic checks. It's, it's not perfect, but it's a lot better than Excel.
Yeah, it's good to know. Because I've in instances where it says the birth date of the baby that we're trying to test right now was in like 18 something, and I know that the person has put it in wrong.
Yeah.
And it's like, you can see that sometimes, but as you say, if you have a format that doesn't allow it, then that's
exactly that. I think this kind of thing is kind of forcing people not to make mistakes.
Yeah.
Having those logic checks.
Yeah, thank you.
Well, thank you very much for the speakers, and Britt and Ania, for organizing the session. I'm really learning a lot. I was really disappointed that Matt didn't bring his harmonica today.
Yeah, that was my other
Well,
question.
27th of September, I am performing at GOS-ICH in the Winter Garden, so if you're around, come along.
I wanted to ask you two things. So the linkage process between your different data sets seems to be very key and very complex as well. So how does it work? And how do you have some internal validity system to verify how this linkage is happening and ensure that it's well done? And I was wondering whether how AI could help interrogating your database or facilitating the linkage. How could that be helping you in your daily work?
Do you want to go first? Yours is really complex.
Yeah, that's the
question.
Okay, I have to get this. So I'm not sure if I can give very comprehensive answer to this. I just can say that, for example, we are working with, just like Matthew mentioned, NHS England as well as ONS. So most of the time they do the linkages already. So they have their standardized system. And I know that ONS have their validation system. So they always give us reports like percentage of linkage and what is the linkage quality. But if we are just talking about a specific data set that we are exploring, just like Nilüfer mentioned already, each researcher is kind of taking on one task. For example, for Nilüfer, it was mental health data. So she is really investigating missingness. Maybe, I don't know, Nilüfer can explain this better, what sort of machine learning methods that she is using. Nilüfer, are you there?
Yeah.
Sorry, can you support me here?
Yeah, so for I think lots of data linkages in the kids environment and cohort, as you said, are not done by us, but they are done by ONS. We can do that. But for example, the way that I am trying to understand, my first step to be able to do the linkage is to understand the data itself, and to have some understanding of if they are systematic data quality biases. For example, I noticed that they are a health provider that does not report ethnicity at all. So that's one of the key findings. It might sound like a basic finding, but that's important when we want to do the data linkage, how we are going to take into account how that is going to affect the data linkage. Yeah, as for AI methods, I don't know. don't have much more information how we are going to use AI methods to do the data linkage.
I think each one has a similar story, that because the whole point is that we as researchers don't get identifiers, right? That's a separation principle. So NHS England does the linkage, they keep the IDs. We just get encrypted keys that tell us, help us link and the attribute data together. But we are always very careful to ask for and get the linked and unlinked data, so we can look at things like, so for those people who didn't link compared to those who did link, how are they different on key demographics, right? That's how I can say, well, they're more likely to be not white, deprived, and so on. So we kind of have these sort of oblique kind of, backdoor ways of trying to get a handle on how good is the linkage. But we just simply can't do well, there's the actual records, there's the gold standard. Let's compare. It's just not available to us. And yeah, AI, I don't know either. I think that's probably very much a developing thing, I'd expect.
Okay, thank you. And I wanted to ask to Niloufar as well regarding the heat map she showed about England. We could see a lot of pretty bright colors around 2018, 2019. So the fact it went down in 2020, 2021, is that due to COVID, or is that due to sort of ULEZ implementation or these type of things? Do we know?
I'm going to share my slide again so other people can see it. Did you mean this slide?
Exactly, yeah, this one. Yeah.
Yes, so we have, yeah, I think lots of it is due to COVID in 2020, 21, and as you can see, then in 22, we are going back to normal levels, like not as before 2019, but higher. That's something that shows up in air quality estimate. These are air quality estimates. But if you want to talk about like mental health service data set, I'm looking at them longitudinally, and there is definitely there is a drop in 2020 because of the COVID. And then right after that, then you can see this spike of increase of accessing mental health service data sets.
Thank you.
I was going to just follow up on your first question because it nicely fed into, we thought it would be nice to have a bit of a discussion around training, and Katie Harron, who is one of the leads for GOS-ICH, has an introduction to data linkage course coming up. So if anyone's interested in learning about the methods and the probabilistic linkage, deterministic linkage, and how that's done, I put a link in the chat and we can circulate it.
Just to follow up the first question as well, I just remember something. I'm not sure if it will help answering some of the aspect of your question, but I know that ONS is using 4 different variables to create an ID for linkage. So they don't rely on a single variable such as NHS number. They also look at birth date and 2 more other variables that I can't remember at the moment, but sounds quite promising. Yeah.
Do you have any genetics level data? So like heritable diseases and that sort of thing, or if families are consanguineous or highly related, or any of that sort of side, or is that not beyond what you do?
Not any child. I mean, we have diagnoses. So if there's a diagnosed rare genetic condition, for example, one thing I should make clear, I didn't make very clear in the talk, is almost all the diagnostic information that we have been using up until this point is in inpatient records. Outpatients doesn't really have it. A&E, it's a bit. We don't really yet know about mental health data, but certainly if a patient comes to hospital with a problem, we generally are able to pick it up in the diagnostic data. But it's not going to be like necessarily, unless it's something like Down syndrome, where that's always one thing. You're not necessarily going to know.
Yeah, so I was just wondering.
I don't know about.
Like you've got children linked, siblings linked as well. So if it has a family with an affected child, how that could impact the other sibling, does that sort of get taken into account?
So again, we can with another baby link in each child. I don't know.
So I mean, for your first question, I'm not sure 100%, but as far as I know, we don't have genetic diseases, but we have information on chronic diseases that comes from maternal health services. In terms of sibling linkages, I think it's possible within kids' environment and health cohort study because we have information on mothers and child and they are already linked and we are following up over the time. So when we get information when the mother gives second or third birth.
Can I add to your, sorry, I feel really bad, I shouldn't be answering questions, but I think the nice thing about both of these data sets is, say you have your study population from GOSH and you can follow up their outcomes, but you don't have a comparison control. So you can use eChild or the kids and environment health cohort to see, well, what's the trend in the general population? Or if you, and that's something we're testing out, we're working with genetics data from Genomics England, and we have the same linked data sets, HES and PD. So you can see what happens to children who are screened for a condition and then see, use eChild a year before screening or generate other comparison groups.
Yeah.
So I think that's a nice additional way of using these data.
So sorry if I missed as well. So how identifiable are the patients? Can you see who they actually are, or is it the idea that you can't? Okay, so we have this ongoing discussion as to whether genetic data is identifiable or not, and at what level. Particularly applying for R&D and that sort of thing, and we have to show that we've pseudo-anonymized, or we don't know based on the genetic information. But we have the argument that if you're doing like whole genome sequencing, only someone who has access to a whole genome sequence and the way to analyze that data is that identifiable. So we have like a conflicting idea of what that is, but very rare disorders that have a specific variant in one family seem like that could be identifiable. But
I mean, the SRS, the ONS Secure Research Service is very much, you can't have any names in there, you can't even have a postcode in there actually, or you can't even have LSOA, which is 1,500 people. So I think probably not in the SRS. I'd be very surprised if anyone's got genetic data in the SRS.
I was about to say something similar to Matthew, that like we talk about just linking environmental data to health data in a really granular level, but in terms of outputting that findings, I think we need another conversation with ONS, because initially that was the agreement that there should be a discussion with them before we output anything, and otherwise every result will be in the middle layer output area, super output area. It is even larger than what Matthew just mentioned.
Thank you. Are we all?
Yeah, I just got a little feedback survey there.
Are they still online?
Yeah, there's people online, but they questions.
Okay.
Yes, I see no questions online, so I don't know if there's any other questions in the room. Otherwise, maybe I have one last quick question. Any training suggestions for anyone who wants to start their journey with administrative health and other data for England?
Training suggestions, you say?
Yeah.
Training, yes.
Like, what's the?
Well, Ania, you and I were on a HES course together, so.
No, I don't mean specific. Well, okay, fine. There's training specific to data, but what are the skills that you think are required, or where would you guide someone who does, say, clinical or lab-based work, who wants to maybe explore this? What's the first?
Do you mean exploring these data sets specifically, or admin data in general?
These specifically, if that's easier.
Okay.
Whichever do you think is an easier question to answer?
I mean, getting to know these data sets, go on the website, look at the user guide, really is the starting point. I mean, in terms of training in kind of using data, I don't know. I mean, my background was working in a hospital, working with data and kind of on the job stuff. So I never did like a formal, course. I think doing a bit of SQL can help, although you don't really need it for this. Learning, I would say R is better to work with these kind of data, because these data sets are very, lots of different files, and it's much easier to work across different files in R than it is in Stata, let's say, but not impossible. Lots of our colleagues do use Stata. So using one of those, learning one of those packages, I think is essential. If you can learn, do anything to do with kind of data management, because a lot of most of what I do actually is data. Even when I'm not a data scientist, when I'm an epidemiologist, it's all data management, really. The actual analysis is kind of like a little bit at the end that's kind of quite trivial almost. It's mostly getting data into shape. And so something to do with data management think would be a good starting point.
So maybe that's a suggestion
Yeah,
for a
that's a good
future
suggestion.
seminar.
Do you want to mention the survey?
Yes, so thank you to all speakers, and thank you for coming and attending the seminar. And please provide us with feedback on the seminar series, and any ideas for topics that you think would be useful are always welcome. So if you could scan the QR code or use the link in the chat, I think, for those online, we'd very much appreciate your feedback.
And if you want refreshments, come in person next time. Hopefully, there are some? Yeah, okay.
Can I just suggest final thing about this question? I just
Oh, yeah.
remember that I personally attended a couple of courses that I found really helpful. So most of them were from Center for Statistics.
Oh, CASC.
CASC
At
courses.
ICH.
I think they are quite helpful. And also like very informal conversations with people who already are working in these data sets would be very helpful too, I think.
Great, thank you, and a very nice shout out to CASC. So at ICH.
Thank you, everyone. Thank you.